right, so can everybody hear me okay? I can't see your screen, so please.
Yeah.
All right, cool. I'll get it started. All right. We're going to do some ILD today. It's going to be kind of in-depth. I'm going to go over kind of the imaging around ILD, what you're looking for, how to kind of differentiate different features on the CT scan, and then we're kind of mostly dive into different types of ILDs and kind of just go through the different manifestations and overall just kind of see what your approach to ILD is going to be. So we're going to start off with a case. So we're going to do Kahoot kind of with this case as well. This is a patient that I saw in the hospital. So he's a 57-year-old male. He has a past mental history of hypertension, anxiety, bipolar, 40-pack year smoking history. He presented to the hospital with kind of like 2 months of this weight loss, and then he started getting a bit more of like shortness of breath with this intermittent coughing. He was found to have pain in his left leg. Also found to have these CT findings on the right, as well as like a small DVT of the right leg as well. He was on 89% originally, so he's put on 2 liters, tachycardia 102. So CT is shown to the right, and he also not shown here had a peripheral pulmonary nodule. The question here, we're going to Kahoot this, is what is the most likely cause of this patient's lung findings? Is it heart failure? Is it lymphangitic carcinomatosis? Is it NSIP, or is it sarcoidosis? Let's get out of here. All right. I didn't spell that wrong on purpose. All right, so kind of split a little bit across the board. So this is good. This is why we got to go over this. So this one is actually lymphangitic carcinomatosis. This is something I had really not seen before I saw this patient in the hospital. So kind of what is lymphangitic carcinomatosis? It's really malignancy spreading to your lymphatics in your lungs. 1 second, I'm trying to work with the point here. So kind of the stuff that, I kind of highlighted here. He's a 40-pack smoking history. He's had weight loss. He's had DVT of the right leg. And they also found to have a peripheral pulmonary nodule, which was actually found to be adenocarcinoma of the lung. So basically adenocarcinoma is spreading to the lymphatics. And other things here is that he also did have a pleural effusion right here as well, which was actually a malignant pleural effusion. So I think this is probably something that a couple of you guys have really never heard of before. So the reason why I took this case is that kind of when you look at this, it looks a little bit like interstitial lung disease, right? There's some thickening of some of the structures. There's some parenchymal abnormalities. There's some kind of like ground glass opacity. So, it can definitely confuse you. And I think that's important because I think interstitial lung, a lot of things can look like interstitial lung disease, especially on imaging. So kind of the first thing I'm going to go for, and I think this is the most important thing about learning imaging for interstitial lung disease, is what constitutes the anatomical unit that the CT is really seeing. And really when you look at imaging on a CT, the main anatomical unit is called the secondary pulmonary lobule. So this is the secondary pulmonary lobule right here. And the way it's set up is that here's the bronchus, here's the artery right here. And basically this goes into a bunch of different acinas, which have alveoli in those acini. So there's a bunch of alveoli that constitute this acinus right here. There's multiple of those. Here is kind of it looking anatomically, where here is there's a terminal bronchiole right here. Here is your pulmonary vein. Here's your pulmonary vein right here. So this is kind of the secondary pulmonary vein. Here's all these sinus here, which are constituted by little alveoli. So things that happen to the lung is really happen to this secondary pulmonary lobule, and you can see these things on CT scan. So the first non-specific finding that I'm going to go to is, and we kind of saw in our last patient. So here is the interlobular septa right here. And within that interlobular septa is your pulmonary vein, and also running along that is your lymphatics. They eventually run back and meet up with your pulmonary artery, your terminal bronchial, and your pulmonary artery and terminal bronchial, and then those basically will create bronchovascular bundles. So right here, it's kind of cool, this imaging to the right, that you can see this patient's secondary pulmonary lobules right here. You can see them right here. They're definitively outlined, and they can be outlined for a multiple different of physiological reasons. A lot of different disease states can cause thickening of this interlobular septa. So it's pretty non-specific. So the first disease state that can cause thickening of it is just basically water, right? So you can get fluid in that interlobular septa. So someone who has either, let's say, heart failure or DAH, that can cause, so heart failure will cause pulmonary congestion. That pulmonary congestion will come back to this little pulmonary vein here. It will cause congestion of these interlobular septas, and then you can see the interlobular septa on a CT scan. Fluid is usually going to be smooth thickening. So here's actually a patient. You would think this is interstitial lung disease, this picture right here, but this is actually a patient with heart failure. And heart failure is causing basically increased thickening of their pulmonary veins from pulmonary venous congestion. And you can see, and I really like this picture here because you can see these big outlines of the interlobular septa all around. So next thing that can cause thickening of this interlobular septa is cells. So here's a picture of actually a patient with lymphoma. And you can see again that all around this lymphoma, you can see thickening of these interlobular septa. Basically, because they have the lymphatics are completely congested with lymphoma cells. So you can actually see this outline, you can see this thickening. So cells, you can get malignancy, you can get sarcoid. Those sarcoid will usually be more nodular because it causes kind of granulomatous thickening of the interlobular septa. And lastly, you can also even see infections, usually like viral or PCP. Last thing that can cause thickening of that interlobular septa here is going to be collagen. That's just a picture of ours. So patients with fibrosis can cause thickening of the interlobular septa, but it's usually going to be more regular looking. So you can see the CT scan here, it's a bit more irregular. So collagen can do this as well. And that's patients, so this is patient with, I think, had UI, like early UIP, even NSIP can cause thickening as well. The next thing that I was going to go into is going to be what are ground glass opacities. So I think we always hear about ground glass opacities and kind of what constitutes ground glass opacities. What is the anatomical, what are they on an anatomical basis? So the things that ground glass opacities are on an anatomical basis, basically they're something going on in the lung that really can't be totally seen and totally outlined by the CT scanner because it's at a lower resolution. So what it does is that it ends up obscuring it ends up kind of partially obscuring the lung. But what is the difference between consolidations and ground glass opacities is that ground glass opacities, you can see the vasculature, right? So here this is actually a patient with COVID, and you can still see the vasculature leading up inside the ground glass opacities. So that's kind of what differentiates that versus consolidations, which consolidations, you really can't see anything within a consolidated unit. So ground glass opacities, what they constitute is something really going on the Essener level. So it can even be Essener thickening, or it can be Essener like partial or alveolar partial filling. So it's really something kind of going on in the alveolar level. And I won't go into it too much, but what ground glass opacities, I think the big thing you should take away is that when you see ground glass opacities, there's usually something active going on. So someone actually did a study in which they looked at ground glass opacities, and they eventually did biopsies, and about 85% of the 85% of the time for ground glass opacities, there was some active process going on. So that's kind of what you should be thinking when you see ground glass opacities. It's like, okay, well, what's going on right now? And that active process can be a lot of things. It can be infection, like a viral pneumonia. It can even be fluid. It can be heart failure. It can be diffuse alveolar hemorrhage. In some cases, it can be malignancy as well. Not always. Yeah, my writing is not good today. So those are kind of the things that you really want to watch out for ground glass opacities. It can be infections, it can be malignancy, it can be fluid, but you just got to know that there's something likely going on in the lung that's active right now. But the differential diagnosis is really huge and wide. So lastly, the thing that I was going to go through is signs of chronic fibrosis. So I kind of went through some of the signs that you see on CT scan. I went through septal, bronchovascular, interstitial thickening. I went through ground glass opacities. These are pretty nonspecific. They can be, secondary to really a range of etiologies. But these signs that I'm going to go through next are a bit more specific to chronic fibrosis. So the two things that I'm going to look for is like traction bronchiectasis. So you guys see here, this long molecule is kind of widened. It's widened here as well. So this is a sign of chronic fibrosis, in which basically you have parenchymal abnormalities, and those parenchymal abnormalities end up pulling that bronchus apart, basically from traction from the scarring, causing traction bronchiectasis. So you can see that pretty well right here. And the one that, and you can see traction bronchiectasis in a bunch of different diseases, UIP, NSIP, even chronic hypersensitive pneumonitis, sarcoid, or even pneumoconiosis. You can see it as a sign of fibrosis. But honeycombing, which you can see, so honeycombing, you can see here, these kind of cystic lesions all around the bases of the lung. And actually, to be honeycombing, there has to be at least like 2 of them in a row. These are a bit more specific for a UIP pattern, or what people also call like idiopathic pulmonary fibrosis. You can see it in like some of the more chronic lung diseases as well, but these are a little bit more specific for this kind of specific entity, and these 2 signs by themselves are a bit more specific for chronic fibrosis. All right, so the reason why I really went through all of that is when you're thinking about, is this ILD, history, physical, exposures, medications are everything. But I mean, I think you really first need to consider, is this pulmonary edema, causing, interlobular thickening that kind of looks like ILD, versus is this an infection causing, really can cause either that interlobular thickening, or the infection can even cause ground glass opacities, or, in some cases, is this a malignancy? Pulmonary lymphoma can look kind of like interstitial lung disease with interlobular thickening. So the first thing that you really need to think about is, is it one of these? And you need to think, do I need to rule them out? Do I need to get a BAL to rule out, infection, diffuse alveolar hemorrhage? Do I need to get a biopsy to rule out malignancy? And those are the first things you really kind of need to think of. Just because the imaging findings on ILD can be non-specific at times, and can look like other things, especially heart failure. All right, next question. So this patient's a 32-year-old female. She has a past medical history of hypertension, hyperlipidemia, diabetes. She presents with low-grade fevers, arthralgia, and dyspnea for the past few weeks. She lives in the Northeast and has no travel history, occupational excursions, or illness contacts. Past medical history is not contributed. She takes no meds. Base physical exam, vitals all normal. Labs are normal. Her spirometry reveals a FVC of 65%, an FEV1 of 75, and an FEV1 FVC ratio of 69%. The chest CT with contrast shows bilateral hilar and mediastinal and subcarinal lymphadenopathy, along with bilateral small lung nodules with a perihilar distribution. TB skin test is negative. So the question is, which is the following next appropriate step in management? And we'll head back to Hoot. All right, let's see who's on the leaderboard. All right, Kurps, good job. All right, only 20 seconds on this one. All right, looks like we got 3 for a biopsy. Anyone said that, you were right. Does anyone explain why they wanted to do a biopsy here? I don't have the chat open, so anyone got it right?
To evaluate for sarcoid.
Perfect, yeah. What kind of stuff kind of made you think about sarcoid here?
The bilateral mediastinal lymphadenopathy and the nodules. And I know it can be restrictive on PFTs or obstructive on PFTs.
Yes, nice, perfect. Yeah, that's exactly the stuff that we're talking on. And I'll talk about this pretty soon. But yeah, the things that kind of turn you on to say this is probably sarcoid are this lymphadenopathy and the mixed restrictive and obstructive PFTs. So that kind of gets to our first part of our algorithm, which is this one is the one that Dr. Kane teaches. So granulomatous is kind of our first section for interstitial lung disease, and this can be sarcoid or it can be borreliosis. So next, kind of going into sarcoid. So what is the pathophysiology of sarcoid? And it's kind of interesting. It's definitely an environmental and genetic contribution. So really the way I think about it is someone is oversensitized to creating type 4 hypersensitivity responses, which are, granulomatous responses. The fact that it's, partially environmental and it's probably due to some unknown antigen is proven that when the World Trade Center fell, that entire area around there had a huge spike in sarcoidosis, likely from antigens in the air, from basically the classic 2 towers. The other thing that's kind of crazy too is some studies have found actually mycobacteria in a lot of these lesions, but that didn't actually have a cell wall. So it's probably some sort of oversensitized type 4 response to some sort of unknown antigen. And the way that sarcoid happens, so here's the pathophysiology here. So here are some bronchioles, here. And, it's the antigens are in the airways. So the granulomas, which are here's some granulomas, really form around the airways. So they form around the terminal bronchioles or, even kind of getting back to the bronchovascular bundle. So what that looks like on CT scan is bronchovascular nodular thickening. So here's kind of the bronchovascular here, And you can see these nodules along the bronchovascular bundles, which are actually just small granulomas, which is kind of crazy. Um, so I think it was Amanda who was talking. Um, what is the diagnosis of sarcoidosis? So first, you need compatible, um, kind of just compatible history, physical, imaging findings, which we had here, right? This patient had that CT scan with thickening of the bronchovascular bundle, so thickening of, the bronchus. Um, the patient also had hilar adenopathy. The patient had mixed restrictive and obstructive. And the reason why they get mixed restrictive and obstructive is that they can actually have some occlusion of their bronchioles. When they have those occlusions, they can actually have collapse on expiration. So that's the first thing you need. Second thing you need is a biopsy with granulomas. Um, which we had here, or sorry, we didn't have that here yet, but we wanted to get that. And the reason why you really need this biopsy is because you're going to need staining for fungal and TB organisms, because the third part is that you need to rule out other other diseases that are similar. And the most similar diseases are kind of your granulomatous diseases. These are, bacteria, fungal, parasitic organisms that can hide inside cells from the immune system. So the immune system's forced to create a granulomatous response to wall them off. So the biggest ones are like TB and fungal, especially your systemic mycoses that can cause, hilar adenopathy and granulomatous disease. So that's kind of the diagnosis. You can skip a biopsy in a couple cases. So if it's really, really pathognomonic for sarcoid, patient has like Lofgren syndrome where they have, they might have arthritis, they have hilar adenopathy, and then they have erythema nodosum. You can skip it because the pretest probability is so high. But in all other cases, you really need biopsy with granulomas and without fungal and TB cultures and staining to rule it out. So treatment, does anyone know what the first line treatment is for, uh, anyone know what the first line treatment is for sarcoidosis? I only have one computer today, so I can't look at the chat.
Do you use like methotrexate?
Oh, second line. Methotrexate is going to be second line. So first line is going to be pred, the prednisone, and then if they're on that for too long or they're getting secondary side effects, and they're not going into remission, then you do something like methotrexate or TNF alpha agents. So those are kind of like the ones that you'll think about using for sarcoidosis. All right, cool. So we got that. And sarcoidosis, eventually, I know initially it'll be this kind of like bronchovascular thickening, hilar adenopathy, but you can get scarring over a long period of time. So here's a patient who has some scarring here. They're having some traction on their lung parenchyma as well. Usually it's going to be upper lobe scarring. I like to think about things that are kind of like inhaled. Usually go to the upper lobes more often. It's going to be more upper lobe scarring compared to like IPF, which is going to be lower lobes that can help you. But just remember, any really chronic interstitial lung disease can eventually cause scarring. They can cause, and then some of them, can even cause that honeycombing pattern. Always think about that when you see really bad scarring. It's not always idiopathic pulmonary fibrosis. There's a lot of other things that can still be. But the distribution of the scarring, the pattern of the scarring can help you. All right, cool. So that's sarcoid. All right, next question. It's another tough one. 30-year-old lady is evaluated for a worsening non-productive cough, shortness of breath for the past month. She was recently hospitalized with this, but improved in the hospital, worsened when she returned home. She didn't know her basement had a water damage a couple months ago. On physical exam, the temperature is 37.9, blood pressure is 125 over 83, pulse rate's 94, and respiratory rate's 0.2. Oxygen sat is 93%, breathing ambient air. The lung exam reveals diffuse crackles. CT shows diffuse micronodular opacities and air trapping on the expiratory scan. Bronch with BAL shows a lymphocytic predominance of 70% with negative staining in cultures. Question here is, what is the most important treatment? And the answers are counsel and antigen avoidance, steroids, pirfenidone, or start MMF. All right. Herb, you still up there? All right. So, all right, good job. Nice. Curb still on top. We got Babs next. C-Pup in third. All right, so does anyone know, can anyone tell me why they thought this was counsel and antigen avoidance? You were right if you had that, if you said that.
Seemed like hypersensitivity pneumonitis just based on the timeline of improvement in symptoms in the hospital and then worsening when she went back home. So the biggest thing will be avoiding the cause or the trigger of the hypersensitivity. So that's why I chose A.
Perfect. Yep. Absolutely. So yeah, exactly what you said. There is some exposure, and then she kind of also had kind of also had an exposure challenge when she went home again. She got kind of short of breath again. The other things that is the CT scan with these kind of diffuse micronodular opacities, the air trapping as well, the bronch with BAL with negative staining in cultures. So the counsel and the antigen avoidance was key. So this kind of gets to our second part of our ILD algorithm. And our second part is going to be inhalational. So inhalational can be either organic, and that type of sensitivity pneumonitis, organic, basically organic, very, very small matter, which forms in the lungs and cause a hypersensitivity response, or inorganic, and these are our typical pneumoconiosis like silicosis, asbestosis, coal workers' pneumoconiosis. So that's our inhalational is kind of our second category. So hypersensitivity pneumonitis. What kind of happens here is, you have inhaled antigens, and it can be a bunch of different antigens. And most ones we think of are farmers, farmers cough versus what is that, like pigeon or bird fancier lung. There's also humidifier lung. So it's a lot of like different molds that can kind of go into the lungs. And then when they go into the lungs, they go into the acini, and they cause a mixed type 3 and type 4 hypersensitivity response. So they have that type 3 where they have the antigen, then have antibody deposition, complement activation, neutrophilic extravasation. And that's kind of what we're a lot, and then lymphocytic extravasation here. And that's what you're kind of seeing right here is this kind of infiltration of inflammatory cells. But they also have a bit of a mixed type 4 response as well. And they get these like really poorly formed, really poorly formed, opposite of sarcoid where they're really well formed, granulomas, non-caseating granulomas. They mostly affect the terminal bronchial. And because they infect the terminal bronchial here, when the patient breathes out, they can get air trapping. So here's kind of mosaicism here, air trapping here, some air trapping right there as well, where when they're breathing out they need to specifically do an expiratory scan for this. They're breathing out on expiratory scan, the air gets trapped. Because it gets trapped, that parenchyma looks a little bit darker because it still has more air in it. And they can also even get wheezing because of that as well. So it also affects the alveoli, but mostly the terminal bronchial is the anatomic unit that it really affects. So diagnosis, there's not any formal diagnosis, but it really relies on 4 things. So known exposure. So this patient likely had mold in their basement from having standing water down there. Like I said, it can also be birds. I mean, it can be, farmers may get this from different animals. Grain workers can even get it. Flour can do it. People who do bark stripping can do it. I mean, there's a ton of different known exposures to different very small microscopic antigens that can cause hypersensitivity pneumonitis. So you have to have that known exposure. Sometimes you can test them for specific antibodies, and that can count for this. If they have a specific antibody, say to like a bird antigen, that can be helpful. The second thing that you want to look for is compatible findings on history, physical, and imaging. So this patient had really compatible imaging finding, right? So when it affects this terminal bronchial, it can actually look like these small micronodules. So you can kind of see these small micronodules basically throughout the lung right here. So these small micronodules are basically just inflammation of that secondary pulmonary unit. And long term, it can cause kind of chronic fibrosis as well. And if it's chronic, it'll usually be like similar to sarcoid upper lung fibrosis. Third, so we got 1, 2, 3. So third is going to be a BAL with greater than 20% lymphocytes. And when you see kind of a lymphocytic predominant BAL, that really means it's either sarcoidosis, hypersensitivity pneumonitis, or lymphoma. So that's kind of your differential there. And then fourth is symptoms with re-exposure, which this patient also had. So this patient, you don't need all of these clinical findings, but it's kind of the culmination of these clinical findings that allows you to diagnose hypersensitivity pneumonitis. So treatment is first is antigen avoidance. So that's really, really important. If patients are symptomatic, and really you're really treating the underlying problem when you do antigen avoidance. If patients are symptomatic, like if they need to be hospitalized from it, then you're really going to need to start them on steroids. So steroids are more of an adjunctive agent, which is why in this question I kind of asked it that way, which is the following is the most important treatment. So avoiding the antigen is going to be more important than steroids, though there is a reason to do steroids. And you'll do steroids for about two weeks in acute or subacute hypersensitivity pneumonitis. If it's chronic, you'll do it for 4 to 8 weeks before you taper. All right. So next question. I think this is probably the last question we got. So 39-year-old lady, past medical history of hypertension, hyperlipidemia, symptomatic AFib on amio and Eliquis, 40-pack year history of smoking, history of localized breast cancer, status post lumpectomy and radiation. So she presents to your clinic with 2 to 3 months of worsening dyspneial exertion, arthralgias, and weakness. She does own a cockatoo. Physical exam significant for fine inspiratory crackles on lung exam. She has roughing, cracking of the sides, tips of her fingers. Her vitals are normal other than 96% oxygen room air that desaturates to 91% on ambulation. Labs are significant for elevated ESR, CRP, CK of 1500 as well as a positive ANA and a cytoplasmic spectral distribution. The PFTs show a restrictive pattern and her CT scan is to the right. So what histological pattern is the finding on the HRCT most consistent with is the question. All right. All right, NSIP was the correct answer. And I think that's going to be our last question for the day. Right now, I think what we're going to do is kind of just go through the idiopathic, um, ILDs. So our third one is going to be iatrogenic, and this is going to be meds. This is going to be radiation. Here is a picture of radiation where, what's helped with radiation is going to be in this kind of linear distribution. The radiation's in one field. So only part of the lung is going to be scarred and the rest of the lung is going to be normal. So you can see that right down here in the picture. And the last one is going to be, and I had a really hard, this is kind of one of the main teachings I really want to do, is going to be kind of idiopathic ILDs. And there's a bunch of different idiopathic ILDs. They all have a bunch of kind of short-term names for them: NSIP, UIP, AIP, COP, BOOP, and lastly is RBILD and DIP. So what are the idiopathic ILDs? I think the first one, the one I think I saw in the hospital most often, is NSIP. And NSIP, I think the main thing I want you to remember about these is that these are not diagnoses in themselves. They are histological and imaging patterns that denote a certain differential diagnosis. So NSIP, basically what this is, histologically, it's going to be inflammation of, here kind of is your acini, and it's inflammation of the acinar wall. And this can be secondary to a lot of different things. So the causes of this is going to be autoimmune is going to be most common. This patient here actually had antisynthetase syndrome, so they had dermatomyositis causing antisynthetase syndrome. That's which is a subtype of dermatomyositis causing interstitial lung disease. And it gave us the NIC pattern because that's the kind of the pattern of inflammation that autoimmune disease usually causes in the lung. So this kind of type 3 hypersensitivity response, maybe the lupus, will cause, infiltration of these inflammatory cells, and then will cause this kind of inflammation of the alveolar acinar walls. Other causes that can cause this pattern is drugs, and lastly is like HIV. And kind of this alveolar wall inflammation will do a couple things. So, like I said, ground glass opacity is kind of anything histologically that's small, that's causing a morphological abnormality that is picked up by the CT scan, but the CT scan is not exactly, it's a little bit too small to be totally, kind of to be like totally like localized anatomically. So that's not really the right word, but it's too small for the CT scan to really show what it is. So it just kind of looks like this kind of little bit of a pacification of the lung, but you can still see the anatomy behind the lung. Over a long period of time, you can get a little bit of fibrosis as well. So you can get a little bit of traction bronchiectasis. You can get some irregular reticular markings as well from that chronic fibrosis. So diagnosis for NSIP, you really need a lung biopsy unless you have a really, really known exposure. So here you may not need a lung biopsy because this looks like antisynthetase syndrome. The patient looks like they have dermatomyositis. They have an elevated CK. They have an ANA and a cytoplasmic speckle distribution. They have mechanics hands with rough and cracking of the fingers. They have difficulty rising out of chairs. I didn't give it to you, but maybe this patient had a positive Jo-1 antibody, which is the antisynthetase antibody. And then, so, lung biopsy, less clear cause. And then treatment-wise, usually treat the underlying disease, which is usually going to be steroids. So that's NSIP for you, right? Remember, it's a histological imaging pattern that denotes a different differential diagnosis. And you still have maintenance of the lung architecture, so you can still see the acini here, right? The next one is going to be UIP. So what UIP really is a very fibrotic disease, and it's going to be usually caused to either damage or actually some people, especially with IPF, which is on the differential of usual interstitial pneumonia, UIP. It's actually from cellular senescence, so cellular, long-term cellular, like apoptosis and death. So the difference of what you're going to see histology is this huge fibrosis with complete distortion of the anatomy of the lungs. This fibrosis here is actually what causes the honeycombing here. And it's usually going to be more in a basilar pattern that you can see on this side. So it's usually going to be on the peripheral next to the pleura. So there is a differential to UIP as well. I mean, you want to rule out, these other chronic fibrosing disorders, so hypersensitivity pneumonitis, sarcoid, pneumoconiosis, especially asbestosis, can all cause something that looks like this. And then the two specific diseases from an autoimmune perspective that can do this, the big one's going to be scleroderma. And also think about RA can cause this kind of histological pattern as well. Does anyone know what the treatment of UIP would be? There's kind of two anti-fibrotic medications.
What was Nintedanib?
Yeah, remember Nintendanib. And there's one other one. This one's a little harder to remember. Pirfenidone. Just remember that these medications are anti-fibrotic. They basically affect a lot of them, kind of affect like secondary cellular signaling, leading to decreased function of the fibroblasts and decreased collagen deposition. But they don't, they only delay progression of disease. They don't actually like fix disease. Like you're not going to start someone on these and then they're going to get better. They're just not going to get worse as quickly. The only thing that can really fix these patients is going to be a lung transplant. But, the epidemiology of this is that it's usually older patients who get it anyway. Sorry, these are specifically for IPF. So IPF is the idiopathic disorder that presents like UIP. You have to rule out all of these things. And then once you rule these out, you can diagnose IPF. And then, basically the only real treatment for it can be lung transplant, but most of these patients aren't going to be eligible for lung transplant because it usually happens a lot more commonly in older patients. So it's just complete fibrosis, complete distortion of the anatomy is kind of what presents UIP. All right, so that's UI. We got NSIP, we got UIP. I think maybe the last one I'll do here is going to be COPD. So what this is some sort of alveolar injury. So they get an alveolar injury, and what they have once they get that alveolar injury is they get kind of inflammation, and they get plugging of inflammatory debris into their smaller airways. They kind of get this inflammatory infiltrate into their smaller airways that causes plugging of it, and then they get complete alveolar filling with inflammatory debris of their alveolar section. So you can see here, you really can't see any air. You can't see any airspace. You can't see any alveoli. And on imaging, because you can't really see any air, this will look more like consolidation. So COP will look like a consolidation. The way it usually presents is almost exactly like pneumonia. These patients will present with kind of coughing, shortness of breath. They can even have fevers. So it should kind of be on your differential of that. And the injury that can cause COP or BOOP is really pretty much anything. So you have to rule out secondary pneumonia, the secondary organizing pneumonia, and this can be anything infectious, malignant, autoimmune, and autoimmune. And then if you rule that out, then you can say, okay, this isn't secondary organizing, it's COPD. And really to do that, for diagnosis here, I mean, anything can really present with consolidations of the lung. It's most likely going to be pneumonia, and that's kind of what we jump to. But autoimmune disease can do, and malignancies can do it as well. So the DX, you're going to need a biopsy. You're going to kind of have to, you're going to have to see this alveolar fill-in. You're going to have to see this kind of inflammatory debris that's kind of clogging your terminal bronchioles. And then for treatment, similar to NSIP, it's going to be steroids. AIP, this is just, so we're getting kind of late here. So acute interstitial pneumonia, this is ARDS. ARDS without a cause. So basically someone comes in with ARDS of unknown cause is AIP. Some people say you can treat it with, it's an autoimmune disease, you can treat it with steroids, but it hasn't really been proven yet. And the last two are going to be RBID and DIP. So these are only in smoking patients. And when they have smoking, they have kind of this, so here's your terminal bronchial right here. They get this develop of a ton of macrophages. Those macrophages, we call them smoker macrophages, are probably clearing some of the smoking debris. So they get filled up and they plug up your terminal bronchial, and they can also plug up kind of your alveoli. RBID versus DIP, the difference is kind of where those smoker macrophages are. So RBID is going to be more in the terminal bronchial. So it's going to kind of really more present as this central lobular distribution on the lung scan, versus DIP is causing like complete alveolar filling. So it's going to be more ground glass opacities, or usually partial alveolar filling, not full, but usually partial alveolar filling, which is going to be more like ground glass opacities, and sometimes it's severe. You can get like consolidations as well. So those are the difference. Treatment is big, stop smoking, and then plus minus steroids again. The big thing out of here is never use steroids for UIP. It actually increases your mortality like 9 times, but you know, RBILD, stop smoking first, then you can use steroids, and NSIP and COP-BOOP, first line is going to be steroids. AIP is like questionable, but most people will try to use it. All right, and the last section is kind of the miscellaneous stuff I won't go into. So I think the big take-home points that I just want to say in the last, sorry I went over today, before you diagnose ILD, consider all the other mimickers, pulmonary edema, infections, and malignancy. Everything is going to really require that history, physical, really look at exposures, whether they're organic, inorganic, or iatrogenic causes like meds, radiation. Really go over those signs and symptoms of autoimmune disease. And if you can't get it with this, you may need a bronch with BAL or lung biopsy. Yeah, I think I'll stop there. Does anyone have any questions? Sorry, I went over today. All right, let me see who was the winner. I think it was Kurt. Oh, we'll skip this. All right. C-Pop, good job. Bad, good job. And Kerps. All right, Kerps, I 80-pack gum. See everybody.